Okay, let's unpack this. If you're listening to this right now, maybe you're sitting in your car or doing the dishes or just taking a walk, I want you to think about the medicine cabinet in your bathroom.
Right, the standard everyday prescription pill bottle.
Exactly. Think about those orange plastic cylinders. We generally view the things inside them as, contained personal solutions.
Yeah.
You unscrew the cap, you swallow the pill, and the chemical reaction happens strictly inside your own body.
It's a very isolated event, or at least that's what we assume.
Right. But what if I told you there's a medication, a very common one, that fundamentally shatters that boundary? Like a pill so specialized and so incredibly potent that if a tiny fragment of it were to break off and turn to dust on your bathroom counter, it could literally become a localized biohazard for specific people living in your house.
It really forces a complete mental shift, doesn't it, in how we view pharmacology.
It really does.
Because we are conditioned to think the risk of a medication is entirely assumed by the person ingesting it. The idea that a tablet just resting on a countertop could exert a dangerous, life-altering biological force on someone who merely brushes against it. I mean, that goes against everything we assume about modern consumer packaged medicine.
And here's the wildest part. This isn't some experimental radioactive isotope kept behind lead glass in a research lab somewhere. This is a daily, reliable lifesaver for millions of men.
Millions.
Yeah, it is a mass-produced, blue, film-coated tablet that guys take every single morning just to get their basic quality of life back. We're talking about Proscar, or specifically the 5 milligram dose of Finasteride.
Which is exactly why we're digging into the clinical data on this today. Because when you look at a standard prescription label for Proscar, you get the absolute bare minimum of the story.
Right, it just says, take 1 tablet daily.
Exactly. Take 1 tablet daily. It tells you absolutely nothing about the collateral mechanisms. But when we pull the curtain back and look at the comprehensive pharmacological profiles, like the data aggregated in the iMedix database that we're using as our roadmap for this deep dive today, you start to see the hidden architecture of the drug.
The real story.
Yeah, the independent audits, the severe handling protocols, the systemic interactions, it's all there.
Right, because our mission today is to look way past the surface level symptom relief. If you are a patient, or if, someone in your house is taking this, you need to see the whole board.
You have to.
So we are going to explore the fascinating, frankly, architectural biological mechanics of how Proscar physically remodels human tissue. We're going to dig into the embryological reasons behind those terrifying handling protocols I just hinted at. We will look at the heavy psychological trade-offs and how taking this one pill fundamentally scrambles the math of cancer screening.
It's a massive topic.
It really is. So let's start at the ground floor. Before we can understand why this drug is so dangerous to some people, we have to understand the massive mechanical problem it's trying to solve for others, which is benign prostatic hyperplasia, or BPH.
Right. And to really understand BPH, you have to look at the environment of the prostate gland itself.
Okay, paint the picture for us.
So as men age, the cellular matrix of the prostate doesn't just remain static. For many men, it actively proliferates. The gland enlarges.
It physically grows.
Exactly. And because of its anatomical location, it wraps directly around the upper portion of the urethra. This hyperplastic growth isn't just a benign expansion into empty space.
Or it's not just getting bigger in a vacuum.
No, it is a slow, tightening vice grip on the primary outflow tract of the bladder.
Okay, so the plumbing is physically being choked off, like stepping on a garden hose.
That's a great analogy, yes.
But wait, if the tube is just being squeezed by surrounding tissue, why can't we just give these guys a targeted muscle relaxer? Just loosen the grip of the surrounding tissue, let the fluid through, and call it a day. Why do we need a heavy-duty hormonal intervention?
Well, we actually do use muscle relaxers for this.
Oh, really?
Yeah, they are a class of drugs called alpha blockers, and they are very common for immediate symptom relief. But an alpha blocker is essentially just a Band-Aid.
How so?
It relaxes the smooth muscle tone of the prostate and the bladder neck, which, does open the channel slightly. However, it does absolutely nothing to stop the underlying cellular proliferation. The prostate itself continues to grow.
Oh, I see.
So eventually, the sheer physical bulk of the hyperplastic tissue will completely overwhelm whatever relaxation the alpha blocker provides. If you want to actually fix the root cause, you can't just relax the grip. You have to dismantle the vice.
You have to shrink the gland itself. Which brings us to the mechanism of action for Proscar. The clinical literature in the iMedix database calls it a Let me make sure I get this right. A 5-alpha reductase inhibitor.
Let's break down what that actually means, because it is an elegant piece of biochemical engineering.
Yeah, please do.
In the male body, testosterone is the primary circulating sex hormone, but testosterone itself isn't the primary driver of prostate growth.
Wait, it isn't?
No. When testosterone enters the cells of the prostate, it encounters an enzyme, a biological catalyst called 5-alpha reductase.
Okay.
This enzyme grabs the testosterone molecule, and it actually converts it into a much more potent, highly active metabolite called dihydrotestosterone, or DHT.
Ah, okay. So DHT is the real culprit here.
Exactly.
I like to think of this in terms of landscaping. Like, if the prostate is a lawn, testosterone is the raw material, maybe the soil. But DHT is the high-octane Miracle-Gro fertilizer.
That's a perfect way to look at it.
Right. As long as that fertilizer keeps pumping into the tissue, the cells are going to multiply and the prostate is going to swell.
And Proscar works by neutralizing the manufacturing plant. It binds to the 5-alpha reductase enzyme and inhibits its function. It completely blocks the conversion process.
It cuts the power to the factory.
Exactly. And by doing so, it drastically plummets the levels of DHT within the prostate tissue, often by 70 to 90%.
Wow. Okay, so we've cut off the fertilizer, but I want to push back on that for a second.
Sure.
If you stop putting fertilizer on a lawn, the grass doesn't necessarily die, right? It just stops growing faster. So does Proscar just freeze the prostate at its currently enlarged size, or does it actively reverse the damage? Like, how does cutting off a hormone make solid human tissue disappear?
That is the crucial question. And the answer is a fascinating biological process called apoptosis.
Apoptosis.
Right, which is programmed cell death. Prostate epithelial cells are exquisitely dependent on DHT, not just for growth, but for their very survival.
Oh, wow. They need it to live.
They do. So when you abruptly remove that androgenic support by introducing Proscar, the cellular environment changes. The cells don't just sit there dormant. The lack of DHT triggers a signaling cascade within the cells that essentially tells them their structural support is gone.
Like kicking the legs out from under a table.
Yes. It initiates a process of gradual self-dismantling. The cells die off and are reabsorbed by the body.
That is incredible. It's not just halting the growth. It is active, targeted cellular demolition. You are fundamentally remodeling the architecture of the organ.
Precisely. As this apoptosis occurs over time, the physical volume of the prostate decreases. The glandular tissue shrinks, pulling back from the urethra, and that structural remodeling is what ultimately relieves the severe urinary obstruction. The stream gets stronger, the bladder can fully empty, and that chronic nighttime waking subsides.
But the operative phrase you just used is over time, because cellular demolition and reabsorption do not happen overnight. Which brings us to what has to be a massive psychological hurdle for anyone starting this treatment.
The timeline is arguably the biggest point of friction in clinical practice. Because Proscar relies on this gradual structural remodeling of tissue, it requires a minimum of 3 to 6 months of continuous daily use before a patient will experience any meaningful therapeutic benefit.
3 to 6 months.
Yes.
I mean, imagine the daily reality of a guy suffering from severe BPH. He hasn't slept a full, uninterrupted night in 2 years. He is mapping out the public restrooms every time he goes to the grocery store.
It's exhausting.
He's exhausted, frustrated, and desperate for relief. He goes to the doctor, gets his prescription, takes the pill on Monday, and on Tuesday, nothing happens. Wednesday, nothing happens. He has to wake up every single day, potentially experiencing new side effects, and swallow a pill that provides absolutely zero acute relief, entirely on the blind faith that it will eventually work.
That is the definition of chronic management, and it requires immense patient endurance. It's a fundamental disconnect between patient expectation and pharmacological reality.
Yeah, because we're so used to instant gratification.
Yeah, exactly. Most people are conditioned by medications like ibuprofen or antacids. You know, you take the pill, the headache or the heartburn is gone in 45 minutes.
Taking Proscar is like paying a massive mortgage for 6 months before the bank even lets you look at the house you bought. The psychological attrition must be huge. I would imagine a lot of guys just give up.
The abandonment rates for 5-alpha reductase inhibitors can be significant precisely for this reason. A patient will take it diligently for 4 weeks, decide, well, this drug doesn't work, and just throw the bottle away.
Right.
This is exactly why the clinical guidelines and the patient education materials we see aggregated in systems like iMedix hammer home the importance of the treatment timeline. The physician has to set the expectation on day 1. Do not evaluate this drug until Thanksgiving.
Wow. And what happens if a patient does make it to that 6-month mark, their prostate shrinks, their symptoms resolve, and they think, great, I'm cured, and they stop taking it? Does the prostate stay structurally remodeled?
No.
It doesn't.
No, the apoptosis is entirely dependent on the continuous suppression of DHT. The moment you stop taking Proscar, the 5-alpha reductase enzyme is no longer inhibited. It immediately goes back to work, converting testosterone into DHT.
The factory turns back on.
The factory turns back on. The prostate tissue is renourished, and the hyperplastic growth resumes. Within 6 to 12 months of discontinuing the medication, the prostate will revert to its enlarged size, and all those obstructive symptoms will return.
So it's not a cure. It's a lifelong lease on a smaller prostate. You have to take this medication every single day for the rest of your life if you want to maintain the relief.
Which means introducing a potent chemical agent into your daily household routine for decades.
And that reality, the daily, lifelong presence of this drug in the home, brings us to the most alarming part of the data. Because while the patient is swallowing these tablets, the physical pills themselves pose a startling environmental risk to specific people around them. Let's talk about the danger in the dust.
The safety warnings surrounding finasteride are severe and uncompromising. Proscar is strictly contraindicated for women and children.
Right.
But it goes beyond just, don't take this. The drug is highly teratogenic.
Teratogenic, that's a heavy clinical word.
Yeah.
From the Greek, for monster making, right? It means it disrupts the physiological development of a fetus.
Correct. And to understand why finasteride is teratogenic, we have to look back at the mechanism of action we just discussed, the blocking of DHT.
Okay.
During embryological development, if a fetus is male, the presence of testosterone and, crucially, its conversion into DHT is absolutely vital for the normal masculinization of the external genitalia.
Wait, so DHT isn't just a nuisance hormone that makes old men's prostates grow. It is the fundamental building block required to develop male reproductive organs in utero.
Exactly. If a pregnant woman is exposed to finasteride, the drug crosses the placenta and inhibits the 5-alpha reductase enzyme in the developing male fetus. The fetus is suddenly deprived of the DHT it needs during a critical window of development, which can lead to severe congenital abnormalities, specifically undermasculinization or ambiguous genitalia.
Okay, that makes complete sense as to why a pregnant woman should absolutely never ingest the pill. But the warnings we are looking at in the iMedix deep dive go so much further than ingestion. The data explicitly states that pregnant women, or women who may become pregnant, should not even touch crushed or broken Proscar tablets.
This is where the physical properties of steroid hormones become a critical safety factor. Steroid hormones and the drugs that mimic or manipulate them are typically highly lipophilic.
Lipophilic, meaning they are fat-soluble.
Yes. Because human skin is primarily a lipid bilayer, lipophilic substances can be absorbed directly through the epidermal barrier and enter the systemic bloodstream.
That is wild. I mean, unless you put a pill in your mouth, we usually assume it's inert. But you were saying the active chemical in Proscar can just bypass the digestive system entirely and soak right through the pores on your fingers.
If the active ingredient is exposed, yes. And this is why the physical engineering of the Proscar tablet is so important. If you look at the pill, it's a blue modified oval shape, and it is entirely encased in a film coating.
Right, the blue shell.
That coating is not there for aesthetics, and it's not just to make it slide down the throat easier. That film coating is a highly engineered physical safety shield. As long as the tablet is whole and the film is unbroken, it is completely safe for anyone to handle.
But the second that shield breaks, say a pill gets crushed at the bottom of a bottle,
Right.
or someone cuts it with a knife, the exposed finasteride dust becomes an active localized threat.
Exactly.
The hormones can become airborne, settle on the bathroom counter, and if a pregnant partner wipes down that counter with her bare hand, the chemical enters her bloodstream.
And the medical community treats that exposure vector incredibly seriously. The protocols dictate that if a pregnant woman accidentally comes into contact with a broken finasteride tablet, she must immediately wash the area with soap and water and consult her obstetrician. The threshold for risk is that low.
It really reframes how you look at a plastic pill bottle.
Yeah.
It's not just a container, it's a containment vessel.
It is.
And the systemic reach of this drug extends even further than the dust. I was reading through the handling protocols on iMedix, and there is a strict ban on blood donation. Men taking Proscar are completely barred from donating blood.
And they must remain barred for a full month after they take their last pill. If you trace the logic of the teratogenic risk, the blood donation ban is a necessary closed-loop safety measure.
Walk us through that. How does blood donation fit into this?
Well, when a man takes Proscar, the finasteride circulates in his blood plasma. If he were to donate a pint of that blood, and that specific unit of blood was rushed to an emergency room and transfused into a pregnant woman who had just been in a car accident.
Oh my God. You've just intravenously bypassed the placenta.
Yes, you have delivered a concentrated dose of a DHT blocker straight to her developing fetus.
The medical community really has to play 4D chess to seal off every possible vector of exposure. You have to assume the blood will go to the most vulnerable possible recipient.
It highlights the profound interconnectedness of biological systems. When you introduce a powerful hormonal disruptor into the population, you have to track its ripples far beyond the individual patient.
Which is a perfect segue because the ripples inside the patient's own body create a massive diagnostic blind spot. We've established that Proscar physically shrinks the prostate and requires biohazard level awareness. But it also fundamentally scrambles the math on how doctors monitor that patient for cancer.
Yeah.
I want to dive into what we can call the speedometer problem.
This is an area where a lack of patient education can lead to fatal consequences. To monitor prostate health, specifically to screen for prostate cancer, urologists and primary care physicians rely heavily on a biomarker called PSA, which stands for prostate-specific antigen.
Right, this is the standard blood draw that every guy over 50 knows about. What is PSA exactly in a healthy body?
PSA is a protein produced almost exclusively by the cells of the prostate gland. Its primary biological function is to liquefy semen, allowing sperm to swim freely. In a healthy prostate, only a tiny amount of this protein leaks into the bloodstream.
Okay.
But if the architecture of the prostate is disrupted, most notably by the chaotic, invasive growth of cancerous tumor cells, large amounts of PSA spill into the blood.
So an elevated PSA level on a lab report is the flashing red light on the dashboard. It tells the doctor, hey, the structure is compromised down here. You need to do a biopsy.
Exactly. It is our primary early warning system. But the problem is that PSA is produced by prostate cells. And as we discussed earlier, Proscar systematically dismantles and shrinks prostate cells.
Why the apoptosis?
Right. When you reduce the volume of the glandular tissue, you inherently reduce the amount of PSA being produced. Clinical data shows that taking a 5 milligram dose of finasteride daily artificially depresses a patient's circulating PSA levels by roughly 50%.
That is a staggering variable to introduce into cancer screening. I mean, if you were a doctor looking at a lab report and you don't know the patient is on this drug, you're looking at a completely fabricated number.
I know you mentioned the speedometer analogy earlier, and it really is the perfect way to conceptualize this clinical danger.
Yeah, imagine you buy a used car and the mechanic tells you, listen, the speedometer's broken. It always reads exactly half of your true speed.
Right.
If you are driving on the highway and the dial says 35 miles per hour, you know you are actually doing 70. You can manage that risk because you have the formula. You constantly do the mental math.
You adjust for the error.
Exactly. But what happens if you lend that car to a friend or if a valet parks it and you forget to tell them about the broken dial? They get on the highway, they push the pedal until the dial says 65, thinking they're perfectly safe. But they are actually going 130 miles an hour. They are going to crash.
And that crash is what we call PSA masking. Let's say a patient has been on Proscar for years to manage their BPH. Over time, an aggressive cluster of cancer cells begins to grow in his prostate. As the tumor grows, his true underlying PSA level climbs to an 8.0, which is a number that would normally cause a urologist to immediately schedule a biopsy and initiate cancer protocols.
But because he takes Proscar every morning, the drug cuts that 8.0 in half.
The lab report comes back reading a 4.0. Now, 4.0 is generally considered the upper limit of the normal range for many older men.
Oh, no.
If the patient goes to a new primary care doctor or visits a walk-in clinic or simply forgets to tell the phlebotomist that he takes finasteride, that new doctor will look at the 4.0, smile, and say, everything looks great, see you next year.
Wow.
They have completely missed a growing aggressive tumor because the early warning system was muffled.
The burden of advocacy that places on the patient is terrifying. You can't just be a passive participant in your healthcare. Every single time a needle goes into your arm for blood work, you have to be the one to raise your hand and declare, I own a 5-alpha reductase inhibitor. You must double my PSA reading. Because if you forget or if you just assume the doctor already checked your chart, You could die from a math error.
It requires extreme diligence. And the relationship between Proscar and cancer risk is actually even more complicated than that. It borders on paradoxical.
Oh.
Because while it masks the early warning signs, the data also suggests that taking finasteride actually lowers a man's overall risk of developing prostate cancer in the first place.
Wait, so it masks the cancer, but it also prevents it. How does that work?
It comes back to the cellular environment. By starving the prostate of DHT and reducing the overall volume of glandular tissue, you are reducing the cellular turnover rate. Fewer cells dividing means fewer opportunities for a genetic mutation to occur that could lead to cancer. You are essentially shrinking the target area.
Well, that sounds like a massive win. Lower your risk of cancer while fixing your urinary symptoms.
It is, but there is a severe caveat. Long-term studies, such as the prostate cancer prevention trial, revealed a really troubling paradox.
Okay, what did they find?
While the men taking finasteride had a roughly 25% lower overall incidence of prostate cancer, the men who did develop cancer while on the drug had a significantly higher incidence of high-grade aggressive tumors compared to the placebo group.
Let me get this straight. So you are less likely to get cancer, but if you do get it, it is much more likely to be the really lethal, fast-spreading kind.
That is what the data showed, though the exact biological mechanism is still heavily debated. Some researchers hypothesize that by suppressing the low-grade, slow-growing tumors that rely heavily on DHT, the drug inadvertently acts as a selective pressure.
Like it clears the field.
Exactly. It clears the way for the rare androgen-independent cancer cells, the ones that don't need DHT to survive, to thrive and dominate.
It's like using a pesticide that kills off all the regular weeds in a garden, but leaves behind a genetically mutated superweed that now has zero competition for resources.
That's a grim but accurate way to look at the theory. Because of this risk, the FDA and clinical guidelines emphatically state that Proscar is not approved for the prevention of prostate cancer. The risk of promoting high-grade tumors outweighs the benefit of preventing low-grade ones. It really underscores why regular mathematically adjusted prostate exams are non-negotiable for anyone on this medication.
Okay, so let's synthesize what this all means for the daily reality of the patient. We've talked about the cellular demolition of the prostate, the 6-month marathon of patients, the biohazard dust threatening pregnant partners, and the broken cancer speedometer.
It's a lot to manage.
It's a ton. But changing the body's fundamental hormonal balance to achieve all this inevitably impacts other systems. You can't just build a chemical wall around the prostate and expect the rest of the body not to notice the sudden drop in a major hormone. There is a heavy cost to this remodeling. Let's dig into the physical and mental side effects.
The side effect profile of finasteride is deeply entrenched in its mechanism of action. When you systematically lower DHT levels by up to 90%, you are inevitably going to trigger systemic reactions. The most frequently reported and often the most distressing for patients are the sexual side effects.
Which makes sense, given that we are manipulating a primary sex hormone. What exactly are guys experiencing?
The clinical data points to 3 main areas of sexual dysfunction: a significant decrease in libido or sexual desire, the onset of erectile dysfunction, and a noticeable reduction in the volume of semen produced during ejaculation.
And here's where we have to confront a word that appears in the iMedix literature that is truly chilling in a pharmacological context. Persistent.
Yes.
Generally, when we think of drug side effects, we view them as a temporary rental. You take an antibiotic, it disrupts your gut flora, you get nausea. But when the prescription is finished, the drug clears your system and the nausea resolves. Cause and effect are tightly bound. But the independent data explicitly warns that with finasteride, these sexual side effects can be persistent.
Persistent means that the dysfunction, the profound lack of libido, the inability to maintain an erection, can continue indefinitely, even months or years after the patient has completely stopped taking the medication.
That is terrifying. How is that biologically possible? I mean, if the drug is gone and the 5-alpha reductase enzyme wakes back up, shouldn't the body just revert to normal?
It is an area of intense ongoing research, often referred to as post-finasteride syndrome, or PFS. The prevailing theory is that long-term suppression of DHT doesn't just lower a chemical level. It may induce epigenetic changes or cause a profound downregulation of androgen receptors.
What does that mean in plain English?
Essentially, the body got so used to living without DHT that the cellular locks become permanently altered. Even when the hormone returns, the locks no longer turn.
Wow. It's tragic irony. Guy starts taking this medication to get his freedom back. He wants to sleep through the night. He wants to go to a baseball game without mapping out the bathrooms. He takes the pill to reclaim his quality of life. but the trade-off could be the permanent destruction of his sex life. You fix the plumbing, but you permanently sever the electrical grid in the process.
And that electrical grid analogy is surprisingly accurate when we look beyond sexual function and consider the neurological impact, because DHT doesn't just operate below the belt, it is highly active in the brain.
Right, let's talk about the mental health side effects, because this is where the systemic nature of the drug really shows its teeth. How does a prostate drug mess with a man's head?
It has to do with a class of molecules called neurosteroids. The 5-alpha reductase enzyme we've been talking about isn't just found in the prostate. It is also present in the central nervous system. In the brain, this enzyme is responsible for converting progesterone and testosterone into specific neurosteroids, most notably one called allopregnanolone.
Allopregnanolone. Okay, what does that do?
Allopregnanolone is a powerful positive modulator of the GABA, a receptor in the brain. GABA is your brain's primary inhibitory neurotransmitter. It's the chemical that promotes calmness, relaxation, and emotional stability. Allopregnanolone essentially amplifies the calming effect of GABA.
So it's a natural endogenous anti-anxiety chemical, like your brain's own built-in brake pedal.
Precisely. Now, when a patient takes Proscar, the drug crosses the blood-brain barrier and inhibits the 5-alpha reductase enzyme in the brain. The production of allopregnanolone plummets. You are essentially starving the brain of its natural calming agent.
You're draining the brake fluid.
Yes.
Which explains the cascade of mental health warnings. Without that calming agent, the nervous system runs hot.
The clinical literature is replete with reports of severe cognitive and mood shifts. Patients describe a profound brain fog, an inability to concentrate or recall words. There are documented spikes in severe anxiety, sudden onset of depressive symptoms, and, in rare but tragically documented cases, the emergence of suicidal ideation.
You take a pill so you don't have to pee 5 times a night, and a month later you are dealing with crushing clinical depression. That is a massive paradigm shift for a patient. And I would imagine that if a man already has a baseline history of depression or anxiety, taking this drug is like throwing a match into a powder keg.
Which is why comprehensive patient history is vital. A physician must weigh the severity of the urinary symptoms against the patient's psychiatric history. And the systemic alterations don't stop at the brain. Because you are heavily suppressing a primary androgen, the delicate ratio between testosterone and estrogen in the male body is altered.
And when estrogen gets the upper hand in a male body, you start seeing physical feminization.
Correct. A known side effect of finasteride is gynecomastia, which is the benign enlargement or tenderness of male breast tissue. Furthermore, while the statistical incidence is very rare, there are documented reports of male breast cancer linked to this treatment.
Male breast cancer.
Yeah.
Because the hormonal scales tip too far.
Patients are strongly advised to perform regular chest exams and report any breast lumps, pain, or nipple discharge to their oncologist or primary care doctor immediately.
Okay, so given the sheer weight of these risks, the threat of persistent, irreversible sexual dysfunction, the neurosteroid depletion causing depression, the biohazard risks, the cancer screening math, you really want to make sure you are only taking this 5 milligram dose of Proscar if your prostate is absolutely miserable and you have no other choice.
Absolutely.
Which brings us to a massive, incredibly dangerous trap for consumers. Because some guys willingly subject themselves to this 5 milligram dose, not to fix their prostate, but for vanity. Let's break down the off-label trap and the confusion with Propecia.
This is a textbook example of why dosage and specific medical indication are absolute non-negotiable boundaries in pharmacology. As we've established, Proscar is a 5 milligram tablet of finasteride, engineered to remodel an enlarged prostate. However, finasteride is famous in the medical world for a completely different secondary effect. It is highly efficacious at halting or even reversing androgenetic alopecia.
Male pattern baldness.
Yes. The 5-alpha reductase enzyme is also heavily present in the hair follicles of the scalp. By blocking DHT in the scalp, finasteride prevents the follicles from miniaturizing and falling out. But, and this is the critical distinction for hair loss, finasteride is marketed under the brand name Propecia, and it is administered at a highly calibrated, much lower dose of just 1 milligram.
So 5 milligrams to shrink a prostate, 1 milligram to save your hairline. They're the exact same chemical, just different doses.
Correct. But they are not legally or biologically interchangeable. Proscar is not FDA approved for hair loss. The danger arises when a patient experiencing a receding hairline decides to bypass the system and use the 5 milligram Proscar dose off-label to treat his baldness.
I can entirely see the flawed consumer logic here. We are conditioned by consumer culture to believe that more is better. If I have a headache, 2 ibuprofen work better than 1. So a guy sees his hair thinning, he reads online that finasteride is the magic cure, and he thinks, hey, if the 1 milligram pill gives me some fuzz back, the 5 milligram pill is going to give me the thick, glorious mane of a 20-year-old rock star.
It is a pervasive and dangerous fallacy. Biology operates on thresholds and receptor saturation, not on a linear more is better scale. Taking a 5 milligram dose for a condition that only requires 1 milligram does not result in 5 times the hair growth. The follicular receptors max out their benefit at the lower dose.
So the extra 4 milligrams aren't helping the hair at all. What are they doing?
They are drastically, unnecessarily amplifying every single severe risk we just spent the last 20 minutes discussing. A healthy man using 5 milligrams of finasteride for cosmetic hair growth is willfully exposing himself to a massively increased risk of persistent erectile dysfunction, neurosteroid-induced clinical depression, and severe hormonal imbalance with absolutely zero proven added benefit for his hairline. It is all risk, no reward.
And there is an even more insidious, highly practical layer to this trap, which loops us right back to our discussion about teratogenic dust. A lot of patients actually know that 5 milligrams is too much for hair loss. They understand the dosage difference.
Yes, the internet makes that information very accessible.
But they also know that Proscar, because it's classified as a treatment for a medical condition, BPH is often fully covered by health insurance. Propecia, on the other hand, is considered a cosmetic lifestyle drug and is almost never covered. So a guy gets a cheap prescription for the 5 milligram Proscar, takes it home, grabs a razor blade, and decides to engage in pill splitting.
He attempts to cut the 5 milligram tablet into quarters to approximate a 1.25 milligram dose, simply to save money.
Which shatters the safety engineering we talked about earlier.
It is an incredibly reckless practice. When we discussed the handling protocols, we established that the blue film coating on the Proscar tablet is an active, vital protective shield. The moment a patient applies a steel blade to that tablet to split it, they crush the matrix of the pill. They immediately generate that teratogenic dust.
They are actively manufacturing an airborne biohazard in their bathroom just to cheat their insurance company out of hair loss medication.
The finasteride dust settles on the sink, the floor, the towel. If a pregnant woman lives in that house or even visits and uses that bathroom, she is placed in immediate jeopardy. This is why the clinical guidelines and the aggregated warnings on platforms like iMedix feature bold, unequivocal directives: do not crush, split, or chew the tablet, swallow it whole.
It's not a polite suggestion. It is a structural safety requirement to protect the people around you.
It perfectly illustrates the danger of treating a highly engineered pharmaceutical product as if it were a casual consumer good that you can just modify to suit your budget.
And speaking of how patients casually modify their treatments, let's bring this discussion back to the reality of the patient's daily routine. Because nobody lives in a sterile clinical vacuum. People take other prescriptions, they have a couple of beers on the weekend, they buy vitamins. If finasteride is this volatile, how does it react when it collides with other chemicals in the body?
The systemic interactions require very careful pharmacological management. Let's start with prescription overlaps. A major red flag is combining Proscar with another drug in the same class, most notably dutasteride.
Dutasteride, that's another 5-alpha reductase inhibitor, right?
Yes, and it's even more potent, as it inhibits both type 1 and type 2 of the enzyme. Sometimes a patient isn't getting the relief they want from finasteride, so a doctor might prescribe dutasteride, or a patient might source it independently. Taking both simultaneously is highly problematic. It compounds the hormonal blockade, drastically increasing the severity of the sexual and psychiatric side effects, while offering absolutely no added therapeutic relief for the prostate.
It's basically hitting the same nail with 2 hammers. You're just damaging the wood. What about drugs that aren't for the prostate?
We have to look at how the body disposes of finasteride. The drug is metabolized in the liver primarily by an enzyme pathway known as CYP334. This enzyme is essentially the body's chemical garbage disposal. However, there are many common medications that act as CYP3A4 inhibitors. They slow down or block this garbage disposal.
What kind of common medications?
Antifungals like ketoconazole or certain antibiotics like erythromycin. If a patient on Proscar gets a fungal infection and starts taking ketoconazole, the liver suddenly stops processing the finasteride efficiently.
So the garbage backs up.
Exactly. The levels of finasteride in the blood begin to spike well above the intended 5 milligram dose. This sudden accumulation can amplify the systemic side effects rapidly, leading to acute dizziness, pronounced breast tenderness, or a sudden crash in mood.
Okay, so a patient needs to be hypervigilant about prescription interactions. But where I think a lot of people really stumble is the supplement aisle at the pharmacy. Because there is a pervasive assumption that if a pill is sold over the counter, or if it comes in a green bottle with a picture of a leaf on it, it must be inherently safe.
Ah, the natural is safe fallacy. It is a massive blind spot in patient safety. A perfect, highly relevant example in the context of Proscar is an herbal extract called saw palmetto.
Right, you see saw palmetto marketed everywhere for prostate health.
It is heavily marketed to older men. What many patients, and frankly some physicians, fail to realize is that saw palmetto actually possesses its own mild 5-alpha reductase inhibiting properties. It operates on the exact same biological pathway as finasteride. Oh, wow. So a guy taking his daily Proscar might still be waking up a couple of times a night. He goes to the pharmacy, sees a bottle of saw palmetto, thinks, hey, it's just a natural herb. I'll add this to my routine to give my prostate a little extra organic help.
And without realizing it, he is unwittingly double dosing his prostate. He is stacking a pharmaceutical inhibitor on top of a botanical inhibitor. He assumes he's being proactive, but he's actually increasing the likelihood of tipping himself over the edge into persistent erectile dysfunction or neurosteroid depletion.
It is the exact same danger as taking dutasteride. It's just wearing a friendly natural supplement disguise. You have to treat every supplement as an active chemical agent.
And what about alcohol? I assume washing a hormone-altering pill down with a martini isn't ideal.
While ethanol doesn't directly interact with the molecular structure of finasteride, it heavily exacerbates the physiological side effects. One of the common physical reactions to Proscar, particularly as the body adjusts, is orthostatic hypotension, a sudden drop in blood pressure when standing up, leading to dizziness or lightheadedness.
And alcohol is a vasodilator. It relaxes blood vessels and lowers blood pressure on its own.
Precisely. If an elderly patient takes his Proscar, consumes a few glasses of wine, and then stands up quickly to use the restroom in the middle of the night, the compounded dizziness drastically increases the risk of a severe fall. And in that demographic, a fall often means a hip fracture, which carries its own high mortality risk.
So we have explored how to take it, what happens when you alter the dose, the danger of splitting it, and what happens when it collides with herbs and alcohol. But there is one final, incredibly fascinating protocol we need to cover. What happens when the treatment fails, or the side effects are too severe, and the patient needs to throw the pills away? Because you can't just toss a biohazard into the kitchen trash.
The disposal guidelines for finasteride are uniquely strict, and they are designed entirely to prevent environmental contamination. The absolute gold standard, the preferred method, is to use a formal pharmacy take-back program, where the medication is secured and destroyed in a specialized high-temperature medical incinerator.
But practically speaking, not everyone is going to drive back to the pharmacy to drop off 6 leftover pills. What is the protocol if they have to throw it away at home?
If a take-back program is unavailable, the home disposal method requires the patient to deliberately mix the intact tablets with a highly unpalatable substance. The guidelines specifically suggest used wet coffee grounds or dirty cat litter. You mix the pills into this waste, seal it tightly in a plastic bag or an empty jar, and only then can you place it in the household trash.
I am fascinated by the coffee grounds method. We are basically engaging in pharmacological camouflage. And the reasoning is twofold, isn't it?
It is. The immediate localized reason is to make the chemical mixture so visually and aromatically disgusting that a curious child or a scavenging pet like a dog will not accidentally ingest the tablets out of the garbage can.
But there is a secondary rule that is even more indicative of the drug's power. You must never ever flush Proscar down the toilet or wash it down a sink.
Never. And this is where the ecological impact comes into focus. If you flush finasteride, the active compound is remarkably resilient. It can often survive standard municipal wastewater treatment processes. If those active molecules pass through the treatment plant and are discharged into local rivers or lakes, you are introducing a potent synthetic hormone disruptor directly into the aquatic ecosystem.
We have to treat a single 5-milligram blue pill like a rogue chemical agent. We bury it in cat litter so it doesn't accidentally feminize the fish population in the local water supply. It really puts the immense power of this medication into perspective.
It is a profound responsibility, but I think it is also crucial, after spending all this time detailing these terrifying protocols and severe side effects, to ground ourselves in why this medication remains on the market and is taken by millions of men daily. If you look at the real-world utility, it clearly serves a vital purpose.
Right, because for the guy who is trapped in a cycle of sleep deprivation, whose life is dictated by the proximity of a bathroom, This drug is a lifeline. I was looking at the community reviews on the iMedix platform, guys like Zach and Oliver. They rate Proscar incredibly highly. Oliver actually left a review calling it the best drug among all I know for BPH.
Hmm.
For him, the relief from that physical obstruction is absolutely worth the risk of the side effects.
Efficacy is the ultimate driver. It physically works. And platforms like iMedix provide a crucial service not just by aggregating these reviews, but by strongly contrasting verified FDA-approved medications like Proscar against the massive, dangerous gray market of unapproved international analogs.
You look at the database and you see all these warnings for drugs like Comagra, Fidelista, Fildena. These are non-FDA approved generics that people buy online to avoid going to a doctor.
And that contrast is vital. Think about everything we just discussed regarding Proscar. If a verified, rigorously tested, FDA-approved pill requires the patient to understand embryology, monitor their psychiatric health, adjust their cancer screenings, and use dirty cat litter to throw it away safely, imagine the compounding, terrifying risk of taking an unregulated knockoff. When the biological mechanisms are this powerful, you absolutely must know that the chemical structure of the pill matches the label exactly. There is zero margin for error with gray market pharmacology.
It is a phenomenal point. Okay, let's pull back and do a rapid-fire recap of the massive biological journey we've been on today. We started with the simple mechanical problem of BPH and discovered how Proscar acts as a chemical architect, starving the prostate of DHT to trigger targeted cellular demolition and shrink the gland over time.
We examine the sheer psychological endurance required by the patient to weather that 3 to 6 month waiting game, enduring the side effects without immediate relief.
We uncovered the severe embryological risks, learning that the blue film coating on the pill is a literal safety shield, and if broken, it creates a teratogenic dust capable of bypassing the skin barrier and altering fetal development.
We unpack the dangerous mathematical trap of the speedometer problem, highlighting how Proscar artificially halves PSA levels, masking early signs of prostate cancer, and requiring vigilant patient advocacy in the clinic.
We explored the heavy systemic trade-offs, the potential for persistent, irreversible sexual dysfunction, the depletion of neurosteroids leading to brain fog and depression, the dangers of pill splitting for hair loss, and the hidden hazards of combining it with over-the-counter supplements like saw palmetto.
This exhaustive, multi-layered view is exactly why comprehensive medical databases and independent audits exist. The goal is to elevate patient awareness from a simplistic take one pill daily directive to a holistic understanding of how a single chemical intervention ripples through a patient's neurochemistry, their household, and their long-term health trajectory.
It is about seeing the whole board. You have to understand the weapon you are using. And as we wrap up this exploration, I want to leave you with a final lingering thought to ponder on your own. We just talked about the extreme lengths required burying pills in coffee grounds to prevent unused finasteride from contaminating the municipal water supply. But what about the pills that are used? Millions of people take potent hormonal medications every single day, and their bodies naturally excrete the active metabolites of those drugs into the wastewater system through their urine, completely bypassing the cat litter protocol. If a single broken tablet of finasteride requires such intense caution to keep it away from human skin and out of our rivers, what does that tell us about the long-term invisible ecological impact of the millions of synthesized hormonal metabolites currently circulating in our global environment? It makes you wonder if the future of medicine isn't about engineering stronger systemic pills, but rather inventing entirely new, highly localized ways to heal a single organ without flooding the entire biological ecosystem.
That is a staggering and deeply unsettling perspective. It forces us to acknowledge that human pharmacology does not end at the boundaries of the human body. The medicine we swallow inevitably becomes the environment we live in.
It's a profound thought. The pill's so specialized it can be a biohazard to touch, yet a daily lifesaver to swallow. It's a lot to process. Until next time, keep asking the hard questions and always look beneath the surface.